Hey, Adam.
Hey, how are you?
Good. How are you?
I'm all right. Okay.
Chris and Jennifer are going to be able to attend that meeting with Ken and Michelle. I think they're both interested in them.
Yeah, well, I think that's a good thing. Do we have a technologist? Do we have Brian?
I'm still waiting to hit. I'm waiting to hear from Tom, and if I don't hear from him, then I'll figure something out. But he usually responds pretty quickly.
Yeah.
Morning, everybody.
Good morning.
Morning. Adrienne's going to be 5 minutes late. She just sent a message.
Okay, great.
We can handle that.
Yeah,
You all hear that noise?
yeah, it was a little scratchy there. Don't know what
Hey,
that-
Jennifer. Hi, Michelle.
Hello. I'm gonna stay off video for just a few minutes until the
That's fine.
class starts.
That's
Hey everybody,
Okay, great.
I'm gonna stay off video
Yeah.
because I'm at Starbucks. I'm also gonna stay on mute except for when I'm speaking, just so that y'all don't have to hear all the background noise.
right.
And I think there was an email with all the questions up there. Found it.
There is. I mean, it's important to say that we don't need to stick strictly to them. I
Of
mean,
course.
you guys are here because you bring expertise. You know, we want to hear you.
Yes, I just wanted to have this in front of me
Yep,
as
yep.
we're going through.
Yep, starting point.
And I don't know if everybody got the message from Adrienne. She's gonna be about 5-10 minutes late.
Okay. Yeah.
So
Okay.
here.
Is Brian joining us too?
The RSVP, yes, I believe.
Okay.
May want to
Yes.
ping them just for fun, because this CRISP is a tech, they provide technology, so we very much want. Oh, and he responded to my email this morning with a few questions, so it's certainly on his radar.
Yeah, I just may want to remind him. Michelle, is there anything that you can inform us about? We sometimes on some of these interviews, we end up doing a little too much background and we don't get enough into sort of the consent issues or the especially separate from, healthcare. We've been talking to a lot of healthcare folks. I don't know if Chris is dealing with non-healthcare stuff either in terms of any of the social
Yeah.
factors.
So CRISP has started a program called CORI, where they're kind of branching into the social determinants of health sector and community-based practices. They're looking at the essence of that program is, let me see, I actually have a little write-up.
What is it called again, please?
CORI, CORIE, and they're looking at using the Z codes, pulling Z codes into CRISP.
Okay.
They are also trying to map data from their assessment tool to the CRISP template for automation. So they're pulling, like when EHRs have a social determinants of health assessment tool within them, they're trying to map those data points or data elements into the assessment tool that CRISP has so that they can display that information in CRISP
Okay.
to other providers. They're also looking at, right now, some of it's manual entry, but that's from healthcare into CRISP so that other providers can see the SDOH screening that's been done. But then they're also working on a referral program. So that's kind of like the SDOH. So it's like a kind of a morph. They're taking the SDOH screening that's done in the healthcare facilities, because in the FQHCs, there's a lot of SDOH screening that's done.
Right.
They're taking that screening, they're trying to map it into fields so that that can be displayed within the health records on CRISP for all the other clinical people to see. Then the second part of CORI, the second goal of CORI, is to work out a referral system to the community-based organization. So they're like integrated. Right now they're integrated with YMCA and Giant Foods for like the Giant Foods diabetes nutrition programs, et cetera. And they're looking at that as a closed loop referral system, which allows for the COB to report back that the referral was received and that the patient's been seen. And if they have a request for additional information or want to report back anything vital from that encounter.
Can I ask you, why Giant Foods?
Giant Foods has got in DC, there's they've got a very robust nutrition program that they do at their stores for different health concerns. The one that I'm most aware of is the diabetes management. They actually have nutritionists at their stores that do one-year classes where the people come in routinely. Right now it's all virtual, of course, but one-year classes where they come in, I don't know, it's like weekly in the very beginning, and then it spans out to more spaced out as the year goes on. But it's general diabetic education from a nutrition standpoint. So that's, and they're just starting this program, and that was really low hanging fruit, honestly. So trying to get something in place so that they can, have precedents set and move from there.
Do you know whether there's a document or anything on a website or anything describing this
Corey?
program?
Let me see.
I mean, I can look it up, obviously.
Yeah, I haven't the internal.
What's your role with them?
With Corey, I don't have a role with them.
Oh, okay. Or with Chris.
With CRISP, I work with their, so I have a couple roles at CRISP. I work with their outreach team. So my specialty is behavioral health and substance use disorder. So I go out to all the providers in DC to help them on board to CRISP at whatever level they're able to on board, whether it's just gaining access for their organization and their providers to see the data available on their patients, or whether it's to integrate them so that they can share data about their patients with CRISP in order to be displayed for everyone else as well for redisclosure. That's my one role. And then the second role is I work with the Department of Energy and Environment to roll out. I'm project manager for the lead registry program within the district.
Oh, yeah. And the interaction, while we've got you here, the interaction between Maryland, DC, and Virginia CRISPs, are they managed independently, or are they come together at some point?
So that's not like a straightforward answer for that one. They are managed, I would say managed in the true sense of the word, managed independently. As far as their business relationships and the actual structures set up, I'm not exactly sure, but they are all managed individually. And they also have different assets available. So in Maryland, Maryland has designated CRISP as their PDMP program, their prescription drug monitoring program. So every single resident in the state of Maryland is in that program. They are not allowed to opt out of it because it's prescription drug monitoring. And all of the physicians who do any Schedule II prescribing are mandated to participate with the prescription drug monitoring, and their payment programs are all like, there's measures within their payment programs, their alternative payment programs, that they have to actually query the PDMP on a certain percentage of their patients, or a certain percentage of their prescription writing, in order to, like, it's a mandatory piece. It's not a metric they can choose. It's a mandatory metric that they have to answer to in almost all of the advanced payment models in Maryland. In DC, they had a different PDMP set up. They're now migrating over to using CRISP, but it's a totally different setup. It's different regulations, different mandates, and it's actually like a separate company that they're working with who was doing the PDMP before, and now they're migrating. So it's a completely different type of PDMP, even though they're both going to be PDMP under CRISP. So he says, not a straightforward answer.
Yeah, clearly, right.
Yeah. And that's just one example. Like, and so CRISP is not the designated HIE for Virginia at this point. They do have some Virginia practices that serve DC Medicaid patients, but they are not the state designated HIE in Virginia. They are the state designated HIE for both DC and Maryland. And then above and beyond that, it gets, in my mind, it gets hairy. I don't fully understand the business relationships, but I know that they are also working with West Virginia. I know that they're working, they have some connection with New York. And I don't think it's for a full suite of services. I think it's just for part of their services.
I can help there, Michelle, if you want.
I was hoping you would jump in. I saw you signed on. I'm like, I hope she saves me here because I don't know the details.
So CRISP is the technology partner for a few other HIEs. So Michelle's absolutely correct about Maryland and DC. CRISP is the HIE entity, so the technology as well as the HIE entity in both Maryland and in DC. CRISP Shared Services is the technology partner for West Virginia Health Information Network. So the WIN is an HIE that uses CRISP's technology. Connie, the Connecticut HIE, is its own HIE, uses CRISP's technology. And recently Alaska Healthy Connect is now also using CRISP technology. And then there are a few other small projects where some other HIEs like New York or Florida, I think the Florida Department of Health project is live. There's a few other HIEs or health departments that are using some of the CRISP technology to implement specific programs. But for those HIEs I mentioned, the CRISP is the technology platform.
Well, good morning, Adrienne, and welcome.
Hi, sorry I'm late. I was reporting an insurance claim. I got into a fender bender yesterday and I didn't realize it would take so long. I thought I could squeeze it in between meetings, so my apologies.
It's quite all right. Hope everybody's all right. Do we need to do introductions here, or is everybody more or less conversing with everybody?
I'm pretty comfortable with, I think I know most folks on the call, but I'm happy.
Jennifer, do you know everyone?
Maybe Jennifer can just introduce herself.
Yeah.
Yeah, I don't, okay, sorry, I'm gonna turn my video on now. So I don't think I do know everybody, but I'll introduce myself. So I'm Jennifer Bernstein. I'm with the Network for Public Health Law, Deputy Director of the Mid-States region. And I've been with the network for about 10 years and focus primarily on public health information and data sharing. So I have a lot of experience around consent issues and laws.
And Michelle is the co-lead of the SCAN team. Of one of our SCAN teams. We have 3, which are legal, technical, and promising practices. And Jennifer is.
Great.
Okay. I think we don't have a whole lot of time, so I guess we should jump in. Adrienne, did you see the questions that we sent ahead of time? It's fine if you didn't. I know how to read them, but.
Yep, I saw them.
Okay. So one thing that one thing worth saying up front is that we're focused on consent, so that's where we'd like to spend the bulk of our time, but explain anything you need to that relates to it, and authorization, identity management, related things, and how you handle them, and in particular, and maybe this gets into the what was it called, the CORI program that you're starting. You could even tell us what that stands for, but in particular, we're interested in non-healthcare settings, right? Lots of activity going on relating to consent in healthcare settings, and we want to know what you're doing. But we also want to know more broadly, how are you connecting, if you're connecting as it relates to consent with other domains.
Great. So maybe I'll just start from, my background is as before coming to CRISP in 2017 as a consultant, my background is all in behavioral health and patient advocacy. So I was a patient advocate at the Mental Health Association of Maryland, and I sat as the patient or consumer representative on Maryland's Health Information Exchange Policy Board. So that's kind of where a lot of my leanings still come from, is that patient advocacy and engagement role. So when I think about consent from a patient perspective, I think about informed consent, right? So someone is giving explicit informed consent to, get a treatment provided or to share information with an entity. From an HIE perspective, though, so I just wanted to kind of level set. From an HIE perspective, oftentimes HIEs talk about consent and they include opt-out and the general kind of HIE opt-out process in that whole discussion. And so just from a level setting perspective, CRISP and all of its affiliate HIEs, all the HIEs that use the technology platform in CRISP BC are all opt-out states. So essentially your information, your medical information is being shared. If you've had any medical treatment in one of these regions, by someone who is sharing information with the HIE, unless you take an action to opt out of that information, right? So we're going to set that aside and just know that we have a very complete and thorough opt-out process. In each affiliate uses the CRISP shared services to facilitate that opt-out process, and then patients can opt back in if they've opted out and they change their mind. They can opt back in, but the data would have been lost between that time that they opted out and the time that they opt back in. We don't store that data. Once someone is opted out, we delete all of their data so that we don't have any accidental sharing of information to the opt-out. So if we set that aside, just note that HIE, all of our HIEs that we work with are opt-out. We also have explicit consent processes for certain types of things. So the first thing that we wanted to work on, and we've been working on it since late 2017, is the ability for patients to consent to share their substance use disorder treatment information. So their information shared under 42 CFR Part 2. And for those of you that are on the call that know, it has
we're there.
Great. So it has a very specific process. The form has specific elements. So we built a consent tool that meets those needs. And we have each HIE is on its own instance of the consent tool. So CRISP has its instance. WIN has their own instance. It's branded. So their forms look like WIN branded forms. CRISP forms look like CRISP branded forms. The forms are configurable. So if the WIN wants to change the options, or for example, we have the current Part 2 regulations they allow us to use the general designation, and that's what all of us use. And I'll just say CRISP Maryland, CRISP DC, and West Virginia are all live with the consent tool with one form, which is patients have the ability to consent to share their Part 2 information with their treating providers using the general designation through the HIE for purposes of treatment and care coordination. So essentially patients are not saying, I want to share with Dr. Pertman, or I want to share with Dr. Ellis. They're saying any of my providers who are on my healthcare team who participate with the HIE can see my SUD information. We are soon hoping to go live with a payer form, which will allow patients to consent for their payer to see their substance use disorder information. As you know, the Part 2 regs don't allow us to lump payers in or anyone else in under that general designation. It's only for healthcare providers, only for purposes of treatment and care coordination as it relates to treatment. So we're live with the healthcare provider form. We're working out the mapping and all that needs to go into the payer form, and hope to go live with that later this fall, because we do work with a lot of the Medicaid managed care organizations who do a lot of care coordination. They do a lot of different programming for their members. And so they are interested in being able to view that substance use disorder information. We do
a quick clarification, just and then please go on. So you're only in opt-out states. is it on all or nothing? Can someone opt out of some information, not others,
No.
or this is just you're in or you're out?
Yep, most HIEs are you're in or you're out, except for New York has a different process where it's, you got to consent to be, it's an opt-in state. There are a few other opt-in states, but it's all in or all out from medical information.
Okay.
And then specific consent for the SUD information.
Gotcha. Thank you.
Sure.
All right. Keep
So we're
going.
planning to go live with the payers later this fall. We are having consents currently registered in DC at this time. Maryland, we're still looking for, we're still training users on how to use the consent tool, and same thing in West Virginia. I know there was a question on the list about lessons learned. I will say
Maybe before you get to lessons learned, can you please explain Corey to us, because that sounds very relevant to what.
Oh
we're
yeah,
doing.
so Corey is the social determinants of health project in DC. It is Maryland also has a lot of social determinants of health work that that we're doing, and they align very nicely with what's happening in DC. But DC got a very specific, CRISP DC got a specific grant from DC Medicaid, and the reason it's titled Corey, I can't remember what the acronym is. It's something community something resource inventory. And it has kind of 3 prongs, the ability to, there will be a CRI, there will be a community resource inventory. There is a referral tool where healthcare providers can make referrals to community-based organizations who provide social services. And then we are looking to integrate with some of the other referral platforms to share that referral information back to the healthcare providers, so that if a doctor provides a referral to, let's say, one of the nutrition programs in DC, they make that referral, the nutrition program accepts the referral, and then they do what we call close the loop on that referral. And they say, yes, we're serving this patient, or no, this patient decided not to accept services. And then we show that information back to all the healthcare providers on that patient's team. So that they can see, oh, they've already got a referral and they're in services with a nutrition provider, they're in services with a transportation provider. That project is slowly expanding. The issue with the referral tool is the same issue with the substance use disorder consent tool, which is it's dependent upon that end organization to be willing to participate, right? So we can't force anyone to accept referrals through the tool, right? So it's just like these are organizations who have an incentive to accept referrals from the providers, and then who are willing to kind of close that loop back to us. But it's not, they're not mandated to do so. They're not necessarily financially incentivized, you know, in terms of they're not getting a specific grant, or they're not getting any specific payment for accepting those referrals, other than the financial incentive to provide services to more clients is really kind of what the main financial incentive for them to accept the referrals are.
This is Brian. A real quick question. As a member of the 360X and the Gravity Project Fire IG sort of closed loop referral standards folks, how are you closing the loop?
Yeah, so we're closing the loop because what they, it generates when someone makes a referral, it generates we have a platform where the community-based organization can come in, they can see their referrals, and then they click a button that says, referral accepted, patient and services. And then we've created in the back end, we're creating like a panel of those patients, which is what our other applications read to know what had actually happened with the referral. So the community-based organization actually has to take an action to tell us what happened at the end of that referral.
So it's on the platform, not based on a message coming back or an API being called.
Correct. We kind of create the message for them based upon what they do at the platform that our other services read. And we do all that in the back end so that they only have one action really to take.
Okay, thank you. I don't want to distract us from
Yeah,
consent
sure.
any further here.
Sure. So the way that consent relates to Corey is the next step that we're going to take, right? So we, we have this substance use disorder consent tool. We have substance use disorder providers using it, working with patients to capture consent, to share their Part 2 information. We do not have a lot of clinical substance use disorder treatment information at this time. So we're not getting CCDs or ADTs or any other HL7 type of message from substance use disorder providers at this time. We're currently building our repo to store those because they have to be stored differently than how we store all the rest of the data. So we're building that, and we'll be working with them to capture clinical information. But what we do get at this time for substance use disorder providers is we get panels of their patients because they want to query and access the patient's medical record in CRISP for those substance use disorder patients that are on their rosters. And so they give us a panel of their patients, just like any CRISP participant or any Colony participant or any WIN participant. They have to give us a list of their active patients in order for them to be able to query to demonstrate to us that they have an active treatment relationship or attest to us that they have an active treatment relationship with those. For everyone else, for all non-SUD programs, we share that information. So when a primary care provider gives us a list of the panels, when the home visitor gives us a list of their patients, we put that into what's called our care team application. And so if you're the patient's, if you're one of the patient's healthcare providers, you can actually go into that application or that view in the widget and see who are the other providers of care to this patient. So you can see their primary care, you can see potentially their managed care organization, you can see, so that it really improves care coordination, the ability to connect those dots. We cannot do that with substance use disorder providers, obviously, because that's Part 2 information. And so right now, what patients are consenting to is that we're able to share that they are in substance use disorder treatment and where, when they appear on a substance use disorder provider's panel of patients. And so essentially what happens when a patient puts in a substance use disorder consent at CRISP, CRISP DC, or the WIN, is that we're now able to read that panel that's in the lockbox once the consent has been filed and say, oh, Michelle has provided consent. And so I can pull her SUD provider's name and now populate that into the care team for the healthcare providers who are participating with CRISP. We ultimately
not information about not information relating to SUD for the patient.
We don't have any clinical information yet. We hope to get some, but at this time, we don't have a place to store it separately from everything else. Once it gets built, then we'll start working with the SUD providers, hopefully in the next 3 months, to start grabbing that clinical information.
One more real quick one, maybe, and that is the role of Corey. How important, this is a sort of qualitative judgment, but how important is it that the SDOH information gets into your platform eventually in some way? I mean, do you view the DC project as sort of a test or a one-off, or where does SDOH fit in a bigger picture?
No,
You're HIE, so mainly it's medical information, but we know that lots of other info is important. So how does that all fit together?
Yeah, that's a great question. So CRISP is a, we kind of serve at the pleasure of our members, right? So participants tell us what they want, what they're needing to have. We have an image exchange platform that was built because it was a huge need to be able to share images across the HIE. And so we routinely ask them, what should our priorities be? Substance use disorder treatment information is one of the priorities for many organizations, mostly primary care, hospital discharge planners, and managed care organizations. Those are the ones that really care whether or not someone is in SUD treatment. Others do as well, but those are the kind of the top 3 that really said, hey, go figure out how to get us SUD treatment information, because we want to know if our patients are in SUD treatment or if we need to refer them, et cetera, et cetera. Similarly, for the other information, the SDOH information, the community-based organizations, the social service organizations, whether or not someone's receiving, supportive housing, or if they're receiving, employment supports or nutrition services, food bank services, transportation services, that was a similar request. And so that it actually is a priority for CRISP and CRISP DC. The other HIEs, I can't really speak to their priority. They all set their own annual goals and work with their own separate boards. But for CRISP and CRISP DC, it was a priority even prior to the grant being released. And CRISP Maryland, we were working with our other funders to kind of fund some of these projects. So SUH data is also critically important to the same entities, managed care organizations, primary care, the ones who have a lot of touches with the patient. And then across the platform, folks are very interested in knowing whether or not someone is receiving services, or if they need to refer them to services because they aren't receiving the services somewhere else. So it is a priority for us. We have annual goals. We have had annual goals the past year. And then additionally, this year, we have more annual goals related to the SDOH work.
If I could interrupt, I'd like to ask a question that will pivot us more towards the consent side of things.
Yep.
For social services. So asking specifically for instance, the Meals on Wheels program that CRISP has started to pilot. If one needs, and I believe the phrasing in the original memo here that I'm reading was something along the lines of, you will only providers will record patient consent for the referral, and only sufficient patient clinical information will be exchanged with Meals on Wheels of Central Maryland, it looks like.
Yep.
That is relevant to how does the patient record a willingness to share their, for instance, diabetic information or coronary heart disease information with Meals on Wheels, or is it some kind of a blanket thing?
Yeah, so it's a couple of things. I'm glad you pivoted us there. This is where I was going. So we currently have the referral tool, which healthcare providers are the only ones that have access to that tool, right? So you're a primary care provider or you're a hospital or whatever, and you're going to make a referral to Meals on Wheels, for example. There is a provision of HIPAA that allows for minimum necessary clinical information to be shared per the healthcare provider's judgment to facilitate a referral if that healthcare provider believes that that referral or that service will improve the healthcare. And I'm sure you guys, I see Jennifer nodding, I'm sure she can give you the citation. It's in an FAQ. We use that to let the healthcare provider who makes the referral, they capture consent, they capture oral consent. So there's a little checkbox in the referral that says patient has consented to allow this referral to be made, right? It's not the same level of like a HIPAA authorization. It's just, hey, I want to make this referral to you for Meals on Wheels. Would you be interested? Are you okay with me sending along your information to Meals on Wheels to facilitate that referral? Patient says yes, they click the box.
So it's covered under TPO. Treatment, payment, and operations.
For the information that supports the referral, yes, it is covered under that provision of HIPAA. Additionally, though, and this is where we're going, is Meals on Wheels specifically, but other community-based organizations. We are right now in the process of capturing use cases and user stories for these community-based organizations and social service agencies, like state agencies, like Women, Infants, and Children's program is a big one, who's really interested in trying to get access to clinical information via CRISP to support some of their program fidelity and coordination of services, et cetera. And so we're right now capturing these user stories and use cases to determine what types of data, right? We have what types of data and what types of services would be most useful to these organizations. And those will be facilitated by actual HIPAA authorizations, which will be captured in the same consent tool that the SUD consents are being captured. So that tool is very configurable. And right now it has Part 2 consents in it, but we can easily and have already working drafts of HIPAA authorizations that can also be captured, stored, and read via API in that tool, where patients can actually say, I am okay sharing for purposes of care coordination, my hospital encounter information with Meals on Wheels of Central Maryland. Then we're able to read that. And when Meals on Wheels of Central Maryland logs in, I can then show them information for only the patients that have provided a HIPAA authorization. That is not live yet. That is still in, we're still there. That's part of our annual goals for this coming year.
Does that same tool allow for maybe recording of consent to share, say, educational information that might be protected by FERPA or child welfare information, or, you know, ...
It
Or is
could.
it only specific to healthcare?
It could be, the form could be used there. You know, there's fire standards for most everything. And so as long as we're able to map, as long as our developers are able to map to a fire standard, the issue there is the schools, our experience with the schools is that they're not super interested in sharing this information. And so we have learned as HIE, you know, in the past as an HIE, that it's important for us to get everyone on board before we start developing and building a tool to make sure that it would actually be used. And so there are some schools, there are some principals who are interested, but in terms of, you know, at the upper levels of doing like a large project, schools are still very protective of FERPA, and they want to hold the consents and they want to manage all of that. And so we do a little bit of work with schools. There's an absentee project in CRISP DC, where we actually get absentee information and we can share that information back with the primary care providers. I'm not super well versed in that project, but if you're interested, I can get you more information on the DC absentee project. But we don't do a ton of work now with the schools just because of their reticence outside of that project in DC.
How is your tool, your consent tool implemented? Is it a internal to the HIE and specific to your HIE vendor software, or is it an independent service that gets called, like Consent to Share or CDS Leap?
Yep. So Leap Orbit built our tool, and we have an open source version of the tool. So all the code is available because it was all built using federal funds through the CRISP DC grant. So there's open source code available for that tool, but we actually, for our purposes, use the Leap hosted instance of the tool. So Leap is hosting the tool for all of the affiliated HIEs, and then we call the Leap API to pull up the UI, as well as the API to check the consents and know what we can share and what we can't share.
If you could share the GitHub or whatever open source repository with us, we'd really appreciate it.
Sure, I can talk to Leap. I'm not sure if it's in the GitHub yet because the grant isn't done, and so they were planning to hold and push all of it in once, but they may have done an initial version. But I'll definitely check with them.
So this is your own instance of the Leap grant, not the San Diego CDS Leap.
Yeah, so it's different than the Leap grant. So the Leap grant is an ONC grant that San Diego is doing. We actually worked with Leap Orbit, which is the developer, and they have a tool called Concentric that they built based upon consent to share protocols that were simplified in many ways and then expanded in a few other ways. Yeah, and we've talked to Dan in San Diego, but I haven't talked to them in a while where they are. But yeah, so that's kind of where we are with consent. We're planning to expand it to the HIPAA authorizations to enable some of these additional use cases for the community-based organizations and the social service agencies. West Virginia is looking to work with WIC as an initial pilot. DC and Maryland are both interested in supporting some of the state agencies. The Maryland Department of Health has some different use cases that they're interested in, potentially WIC, potentially home visitors, and then a lot of the community-based organizations. But we're still doing a lot of data gathering at this time to really understand what data do they need, and how we can make sure that we're limiting it to only, as an HIE, we work mostly with treatment providers, right? And so you don't have to really worry about minimum necessary when you're talking about treatment. And so it's important for us to think through like how are we going to display data? What tools are we going to make available so that these community-based organizations are getting the data that they've been authorized by the patient to have, but only the data necessary to support those use cases. And so that's what we're in the process of thinking through right now.
So I'm looking at the clock. I'm going to try to keep the time. So I want to ask, before we go into more prefab questions, Jennifer, do you have anything you want to jump in with, and same with Daniel?
I don't have anything right now, but
Daniel?
Yeah, the only one question comes to mind, I just asked Brian about it, is are any of the community-based referral organizations, Unitas and Bertha's, operating in Maryland, DC, or Virginia? And are you interacting with them, or are they sort of duplicative of the CRISP sort of suite of services?
That's a great question. So yes, they are all operating. So both Aunt Bertha is operating both in DC and in Maryland, but they have a big footprint in DC. And Unitas is trying to operate. Unitas has a little bit of a different model. They like to go all the way up to the state. They're really interested in kind of being the platform for a state. I do think they have some smaller instances, but based on conversations with them, they're really interested in kind of being the platform. And then, there's still NowPow and others that do have some small footprint in Maryland. We are very interested in working with them. CRISP, we call our referral tool, I should have said this, we call it kind of the referral tool of last resort. So we are not trying to replace Aunt Bertha or any of the other platforms. So we really want to stay in our lane. We really want to, we think that the best role we could play here is displaying the information back to other members of the healthcare team, right? So that more members of the healthcare team know what's actually happening with the patient. And so the reason we built a referral tool is because there were some groups that weren't on a platform or that were on multiple platforms and wanted to be able to kind of consolidate those or just didn't have the money to go purchase a platform or license a platform. And so that's really kind of where we started. We do not see the referral tool as something that we're going to continue to try to expand and compete with the Aunt Berthas of the world. That is not our goal. So we are actively working with Aunt Bertha. I can't say too much. We're still in process of signing some agreements and such. So I'm not sure how public that information is, but probably in the next couple of weeks, I can share a little bit more information. But Aunt Bertha is very interested in working with the HIEs to display the referral information that they have back to the through the HIE. And so what we're contemplating is for the CRISP participants who have a relationship with, who are using Aunt Bertha to make referrals, that participant, it's really kind of, Aunt Bertha sees it as, and CRISP sees it as well, as it's that participant's data. So for example, let's say a MedStar or a, ABC primary care practice, they're using Aunt Bertha to make referrals. They can tell, the potential plan is that they would tell Aunt Bertha, hey, I would like to also share this referral information through CRISP so that other providers can see that I've made these referrals for these patients. And so that's what we're thinking about, is that we would just be this display mechanism for the HIE participants who are using the platform to display those referrals back to other healthcare providers. But like I said, we're still in the process of ironing a few things out, but hopefully in the next couple of weeks, I can share a little bit more information.
Yeah, that would be great. I mean, we're not going to publish for a little while. So that would be great. Anybody else? I'm going to wrap it with just a few of these questions.
So just to follow up on one piece of, so you see,
no.
you're sort of the Rosetta Stone, right? So whether or not there are 2, 3, 4 different referral patterns, you're sort of being able to visualize the patient engagement more broadly for the care coordination team. If I've said that somewhat correctly.
Yeah, so more about kind of getting that SDOH information to the healthcare team as opposed to, serving as all the different tools and et cetera. Everyone's still trying to figure out, the funders and others would probably like something more robust, but as the HIE, we're not really looking to compete with vendors that do a good job in this space and that are meeting the needs of their clients. But we do have the capacity. We have a large group of healthcare providers that work with these patients. And so being able to visualize that information for them, I think is that we're kind of that last link, or that, that final mile.
Okay.
Great. So I think we're going to go, this is a question relating specifically to consent. Obviously branch out if you want to, but what are the roadblocks? What have you, I think it's an important question people learn from. What have you encountered that got in the way of making this, the consent process in particular, as efficient as it can be?
Yeah, so I think the major roadblock, and remember, we're only live with the SUD consent at this time. The major roadblocks are a couple of things. Behavioral health providers, both mental health and substance use disorder providers, were left out of meaningful use incentives. And so many of them are not on very sophisticated EHRs. And so the ability for them to share clinical data is really difficult. So for large health systems that have an SUD clinic, that clinical data won't be as difficult for us to get. But if you're ABC methadone clinic or a crisis detox center and you're on paper records, it's really hard for them to kind of share that data, and it's a huge IT workflow financial burden. And so, and the reason that relates to consent is it kind of, if it's really hard for them to share data, really hard to get data from them, then there's no incentive for them to capture consent for their patients to share the data, because they're not sharing, they don't have any additional data to share. And so that's why we started with the panels and working on just sharing that there is a relationship with an SUD provider, because we are already getting that information and that's much easier for them to send. So that's one roadblock. The other roadblock is related to just workflows and asking anyone, and this is, in anything technology in HIE, asking someone to do one more thing than what they already are doing is not always the easiest thing. And so, as I mentioned, I think before we start building anything, we're using the lessons learned from the SUD consent before we're applying that to the HIPAA authorizations. And so we really want to have nailed down who are going to be our first pilot sites, what do they need, what do they want, and are they really committing to doing this, to capturing the HIPAA authorizations before we actually start building anything or digging into the technology. We're about to expand the substance use disorder consent pilot so that not only the sharing provider, so the SUD provider, can capture the consent, but also the querying provider can capture consent. And that's what a lot of the other HIEs do. So if you're the primary care provider and you want to see all of your patients' information, in other HIEs, it's that primary care provider or that payer or whomever that captures the consent for the patient. I want to be able to see your SUD information. Can we complete this consent together, so that we're kind of spreading out that workflow burden a little bit? Right now, it rests solely with the SUD providers. And that's why I think our numbers of consent are pretty low at this time. One, because they're not sharing any clinical data, and two, because it's something additional for their staff to have to capture.
I want to follow up the workflows I get. I want to follow up on the first roadblock that behavioral health is left out of use incentives. So what does it mean? It's a burden for them, right? And it's a financial burden, and they have no incentive to get consent. Is there anything to do about that, or you just sort of avoid those domains, those services providers?
So it's hard for me because as I disclosed initially, my background is in behavioral health policy and working with those behavioral health providers. And so ignoring them and saying, well, you guys are on crappy EHRs that aren't going to ever integrate with the HIE, or you don't have any EHR at all, it is really difficult for me. And so we're still trying to figure out how we can potentially, and we're talking to them. There's a pilot in DC where we're getting feedback from those SUD providers. Potentially there's other mechanisms to use. There's, some some instances of EHRs, like in DC, there's the regulatory agency requires them to send some data through one system. And so maybe we can integrate with that one system and capture some of that data from that system. Potentially we could, so we're still trying to answer your question. We're still trying to brainstorm and figure it out, but we are going to focus on the initial clinical data integrations with some of the larger health systems who have already integrated and are sharing data with CRISP, but are blocking the SUD information, right? So think large health systems, University of Maryland, Hopkins, MedStar, et cetera, they all have SUD clinics, detox units. They're blocking that data now. So what we're going to likely do is go to them and say, you're blocking it. You don't have to. You can just add that as to your feed and we'll store it over here once we've built that storage. So I don't want to say that we're just kind of avoiding them, but they definitely are not, they're not going to be our initial test cases of getting the data and storing the data. We'll work with those that already have an integration.
And I assume that
Can
this is a prevalent problem elsewhere, that
Well, real quick,
why
Adam,
behavioral health
can you guys
data
hear me?
is not widely shared.
Am I on mute? Can you hear me?
No, Michelle, we can hear you.
Okay.
No, I'm sorry. No.
You know, I just wanted to add to that real quick before you move on to the next thing. So everything Adrienne said is, you know, I agree with everything she says 100%. I did want to also point out, however, that in the outreach, CRISP has a whole department of outreach, and within our outreach, there's 3 of us in DC alone that are specifically dedicated to going out to finding these smaller practices and bringing them into CRISP and getting them participating at whatever level they are able to participate, even if it's just an access level where they're only sending over that patient list, just that panel. And as I said, there's 3 of us in that, and I am dedicated to the behavioral health, substance use disorder, disability services. I'm 1/3 of that team is dedicated to that outreach effort. So I don't think it's fair to say necessarily that they're being left behind. They may be technologically they're focusing there because there's more bang for your buck with those bigger institutions. But you know, I have a list of about 100 providers, and of that list of 100, I've done outreach and been able to pull in like in the neighborhood of 40 to 60 of them, so that whether it's using their practice management tool, we find all kinds of creative ways for them to create that panel of their patients in a digital format that can be accepted at CRISP. So I don't think it's fair to say that they're being left behind. While they may not be the technological focus, they're definitely not being ignored or left behind. We're kind of meeting them where they are and trying to support them the best we can.
Great.
Thank you, Michelle.
What I apologize for talking over you a moment ago. The question I had was how prevalent this problem is. If it is, I mean, that's something to, it seems to me, something to really call out, because everyone says include behavioral health, and structurally it sounds like that's a higher hurdle than just people being stigmatized because it's, you know, it's mental health.
Yeah, it's definitely a problem. I actually have been in conversations with MacPac. I don't know if you guys know MacPac, who works with the Commission on Medicaid, and they advise Congress on lots of things related to Medicaid. And they actually were looking at this specific issue of behavioral health providers and IT. Maryland Department of Health was really interested in trying to support this. The national behavioral health organizations have it as a priority for them. So it is something that is going to continue to be a barrier unless there is some additional financial mechanisms or some other creative ways to. It's always a problem for an HIE. You know, ambulatory integration is not anywhere as near as easy as people thought that it was going to be, right? And so we still don't have a lot of great information from small primary care providers because their EHRs want to charge update fees, et cetera, et cetera. And so there is ambulatory integration just generally is difficult, but with the behavioral health providers, because of their levels of EHRs, sophistication is a huge challenge.
That's great. So I think that my last question, and it's open-ended, and anybody else can jump in, is what are the lessons learned? I mean, we're going to put out a report in which lessons learned are important so other people can learn from it. from what you're experiencing. So it's a, you know, softball down the middle. What have you learned in the course of the work that you're doing that other projects, comparable projects, especially relating to consent, that other people can learn from and apply?
So lessons learned, a couple of things that I've, kind of mentioned. One of the lessons learned is to make sure that your policy and your technology can align, right? And so 42 CFR Part 2 is complicated. It has specific requirements. It has, the HIE general designation, which makes it easier in some instances, but it leaves payers out, it leaves other entities out. And so making sure that we have, and what we're doing with the HIPAA authorizations, we can't just open up our services to a community-based organization because someone has said, I authorize them to see this. And so we want to make sure that the policies that we're putting in, that the policies are supported by law, that they are legal, but that also that we aren't setting some policy up that we can never actually implement technologically. So for example, 42 CFR Part 2 in the paper world is very granular, right? So a patient says, yes, I want to share my information with Dr. Ellis. Please send her my file. They print that file and fax it over or send it over to Dr. Ellis. In the technology, in an HIE world, it's almost impossible for us to support that granular options because I don't know that the Dr. Ellis that Brian picked is the same Dr. Ellis that I have in my system. And so we had to be really careful about making sure that we developed a policy that the technology can actually support. One of my things I say all the time is I never want to give patients choices or options that we can't actually adhere to, right? So you asked a question earlier, Adam, about can patients granularly opt out of things? No, and the reason why is because it's almost at this time the technology just doesn't support that. That's something that we definitely would like to look into and that we definitely would like to be able to support so that patients can say, yes, share all my information to hospitals or share it to my primary care, but don't share it with my dermatologist. They don't need to see my information, or I no longer go to this doctor. So we'd like to provide more granular options, but we can't get too far ahead in the policies of what the technology can actually do. So that's one lesson learned, is to make sure that you understand what the technology, what's feasible with the technology you have before you start actually implementing choices and policies. The other lesson learned is to really make sure that you have all players on board before you, and have a slow rollout before you actually build a lot of technology, get the feedback from users. I mean, this is just good technology development lessons learned, make sure you're getting the feedback, make sure doing a pilot where you're having a few organizations do user testing, but then expanding it into a pilot where you're actually, one of the things we learned specifically is that due to COVID, everything moved to a telehealth situation. Well, it's very likely that behavioral health is going to stay very telehealth as long as the state policies or local policies, reimbursement policies allow that. Well, our consent tool requires a electronic or kind of like almost like a wet signature, right? The patient actually uses their finger or uses the mouse to sign the form, and which means they need to be with the provider who's logged into CRISP and is completing the form with them so that they can sign the form. So one of the reasons that the consents are so low is because they're all doing telehealth and we don't have a way to capture a signature via telehealth. And so that's a huge stumbling block for us that we're right now trying to fix, right? So we may have to have another workflow where we can capture an attestation that a patient signed a paper form and it was mailed back, or maybe we have an integration with some sort of, so that patients are able to DocuSign in the same way they're able to DocuSign the consent for treatment. And so that was another lesson learned, is make sure that you understand the environment as it currently exists, not as it was a year ago when you started building the tool. Make sure that you have built in time to gather the feedback from the users. Make sure that you really understand what the user stories are, not just, hey, I want to see substance use disorder data. We're right now trying to learn from organizations what types of SUD data do you want? Like if we can only get certain types of clinical information, where should we prioritize? Is it treatment plans? Is it labs? Is it discharge summaries? We're going to do the same things with the SDOH information. Where are the organizations that you really want us to, if we had homeless services data, is that more relevant than school data? Like, where do you want us to marshal our resources so that we're getting you the priority information that you want, so that we can really focus and get some incremental wins? So I think mostly that's what, and to note that like things just take time, right? So that even though once the technology is built, Michelle already pointed out, there's an outreach team that goes out and actually talks to these providers. We have a PM specifically for the consent tool in DC that's really focused on doing office hours with providers who are filling out the consent so they can actually make sure that they understand what they're doing and answer any questions. So things take time. You can't just build technology and assume that everyone's going to use it and it's all going to be good because someone asked for it.
Well, this is great, really good. Thank you. I'm going to wrap it up pretty quickly because a few of us have to jump on an 11 o'clock call. But thank you enormously. If we need anything more, we will come back to you. But this was really useful and really on point for us. So thank you.
Great.
Yeah, Adrienne, thank you so much.
Yep, I'm happy for you guys to contact me if you have other questions, and I will try to send along some of that other information. I'll try to get more information on the GitHub, as well as our work with Aunt Bertha when I'm able to
And
share.
Corey, and if we could learn a little more about Corey, if you have anything there.
Yep, I can see if there's, Michelle, let's check with Laura or Ronald to see if there's actually a Corey write-up that we can share. There might be a couple one-pagers.
Yep, I can take that.
Great.
And of course, any specs from Leap Orbit or access to the code would be great.
Yep, I will do that as well.
Great. All right. Thank you, everybody.
Thanks, Adrienne.
Enjoy the rest of the day. Bye-bye.
Happy Thursday.
Happy Thursday.
Thanks, everyone.